All right, guys, Dr. Derek McClister here again. We're talking about Metatarsus Adductus and the correction in hallux valgus. What does the evidence tell us? The agenda for today's presentation are just go over the very basics, talk about a little bit of anatomy, talk about imaging, talk about relevance, evidence for options, and then the conclusion of this talk. So, getting into the basics, it's a congenital uniplanar deformity in the transverse plane. So it's not a skew foot. We're just strictly talking about metatarsus adductus. When you get into the skew foot or other deformities, that's talking about hindfoot deformity with a metatarsus adductus deformity. So just strictly talking about metatarsus adductus. It's a uniplanar deformity in the transverse plane. The deformity is located at the Lisfranc joint line, so the tarsometatarsal joints. It's a common deformity. Incidence is about 1 out of 2 to 1,000 births, which is relatively common. Prevalence of metatarsus adductus, we'll get into the numbers a little bit, but about 22 to 35% of patients with hallux valgus have this. And then patients with metatarsus adductus are about 3.5 times higher to develop hallux valgus over their lifetime, just due to the angulation of the foot and overall anatomy that's based on this, and we'll hit that a little bit later on. And then basics, when you think about metatarsus adductus, what other comes with it? Well, we usually think of obviously hallux valgus, that's what this talk is on, but it's very common to see forefoot issues such as metatarsalgia or these windswept toes that they described, or basically toes that go along with the hallux valgus deformity in that lateral plane. Anatomy. First metatarsal is normal, so you can't really think of it as, hey, it's a metatarsal issue. Yes, they can have a hallux valgus deformity, which causes some difference in anatomy, but in general, if we're just strictly talking about metatarsus adductus, the first metatarsal is normal. The first metatarsal, again, at that first tarsometatarsal joint is angulated medially, which adducts the first, and it really makes the first metatarsal go more medial based, which again is why the hallux valgus deformity can develop. And then the proximal lesser metatarsal shafts are angulated medially as long as their bases. So as well as with the bases, which again adducts metatarsal shafts to the tarsus. So again, thinking about anatomy is basically it goes in towards the midline, not out towards the midline. That's why it's adduction. It's adding to the midline. These are just kind of pictures of what we would call metatarsus adductus. Looking at it, here's a left foot and here's a right foot. On the right image, you can see how that windswept toes are laterally deviated because of how much adduction is happening at that tarsometatarsal joint or the lesser metatarsal deformity. On the left image, not so much, but definitely still present that there is some adduction of the metatarsals, and then the toes are actually going very slightly laterally, so abducting away from the foot. Imaging-wise, what do we have? There's several different methods to measuring metatarsus adductus in literature, and then grading the deformity. Below, normal is 8 to 14. Mild deformity is 15 to 20, moderate is 21 to 25, and severe is over 25 deformity. Again, these are relative values. You can't always hold your head on every single one, depending on how you're measuring it, where you're measuring, and if you're really good at it. But if you're taking boards, this is kind of what you have to know of deformity and what is normal and what is not normal. There's usually 2 measurements that are commonly used. I'm going to say the first name wrong, and the second name is relatively more easy. The Scarletto method, or modified Scarletto method, is very commonly used. It's got some evidence to back it up, which I think most people would tend to agree with. And then Ingalls angle, I usually use Ingalls angle. I'll kind of describe that a little bit later on, but it's usually 3 to 4 degrees lower than the Scarletto method, which is a little bit better evidence-wise to use. I just used Ingalls angles because it's a little bit easier in my hands in my clinic as time really goes. These guys created it and did a paper on the methods of measuring it and which is more reproducible. They found the Scarletto method was the highest observer and intra-observer reliability. So if you're really trying to produce research, you probably should measure it with this method so you get high quality evidence based on the literature that's available. Does that mean you can't use Ingalls angle? No, it just means that, hey, you probably, if you're going to try to produce research, should do both methods so you just have high quality evidence. And then you can compare the two based on your evidence and see if that 3 to 4 degree difference is correct or not. In metatarsus adductus, the IM angle is usually low. Again, because of that anatomy we just talked about, the first metatarsal is adducting with the lesser metatarsals, so the IM angle doesn't really change that much. And so a smart group of people really had to calculate, well, how do we really measure the bunion deformity in this? And this is usually the deformity of the bunion is undervalued, or we don't really grade it correctly if we're not using the correct measurements. UEDL created what I would say is a very important measurement to know, because boards usually test this. The true IM angle is IMA plus metatarsus adductus minus 15. We know that relatively normal is 8 to 14. They're just saying, hey, well, if you measure and you take minus 15, you're going to get a relatively good IM angle, which again is mostly for boards, but also in our world, we know if the patient has a bunion, we see it clinically, we look at it, we measure metatarsus adductus, okay, it's relatively high, okay, we know that the IM angle is going to be higher than that. So just know that the IM angle is lower, it's underestimated, and then there's a correct formula to get yourself to have a decent number for boards and just yourself when talking to patients. And imaging, I'm going to go through this, but these guys created this good paper talking about it, and basically they use these two measurements, and again, comparing the two, they found Scarletto method was better. This is Scarletto method, and then the modified are in this range, and then this is Ingalls angle, which I like to use. Just, it seems simpler. There's not as many dots to point. It takes me a little less time, and then I just kind of add 3 to 4 depending on what my measurements are. And that's my personal way of doing it. Is there a right way? Again, literature is probably going to tell you to do the Scarletto method. If you're just trying to do it simply in clinic to give yourself a rough estimate, I think Ingalls angle is a lot quicker to do. I really like this paper. I thought it was a very smart paper. It's newer, and it really gives you a simplified way of saying, hey, should we correct metatarsus adductus? And if we do correct metatarsus adductus, does the deformity get better just by doing this simple line? So 2026, foot and ankle specialist, level 4 evidence. Basically, they fixed hallux valgus with metatarsus adductus. So they had patients with hallux valgus with and without metatarsus adductus, so relatively the same line, number of patients in the two different groups, and then they fixed it. They did plumb line, which is their radiographic measurement, and I'll show that here in a little bit, and they did Scarletto's method, and then they did IM angle. They measured these. Again, great paper. I really thought this was a simple way to do this for everybody learning metatarsus adductus and maybe when you should fix it or not. And what they do is basically take the medial cuneiform, they draw all these points, which is not very difficult to do, and then they draw a straight line. If, in my opinion, that the second metatarsal is past this line, you're going to get a positive, which means that you likely have metatarsus adductus. And then if it is negative, you're not going to have it, or do not have metatarsus adductus. And what they found is basically people that had negative Scarletto's method were negative in the plumb line, and people that had metatarsus adductus displayed a positive plumb line. And then when they fixed the people that had this positive plumb line, they all went to a negative plumb line. So again, it's a simple way of correcting, knowing, hey, I have this positive plumb line, my metatarsus is past this, and if I correct this deformity, did I get a good correction on it? So I thought it was a simple way of measuring your good correction, because sometimes radiographs are not the best depending on who's taking it, how their foot's positioned, if they're fully weight-bearing or not, depending on how far out from surgery they are. But again, really simple way of measuring, hey, does it look like you have metatarsus adductus. Okay, it looks like a positive one. We probably maybe should correct the deformity with it. If not, maybe you don't need to correct it. So I thought it was really good on paper with that. And again, this is showing after correction. So this would be a positive patient with a plumb line. And you can see drawing that line, the metatarsus or metatarsus adductus is positive. And then after correcting the deformity with a robust fixation, the plumb line is negative. Good evidence. Plumb line is a simple method and clear visual reference for determining metatarsus adductus in hallux valgus patients. So we're all trying to find simple ways to measure things, look at things, and make our job easier. And I thought this paper really highlighted a newer technique on measuring it. Getting into more the why we're worried about this. Ayer kind of led some good studies early in the 2015 timeframe. Foot and Ankle International 2014 level 4 retrospective case series. They had about 600 patients underwent hallux valgus surgery. They measured metatarsus adductus using that Scarletto method, and then they considered it abnormal if it was greater than 20, so maybe a little bit higher than the mild to moderate range that we're thinking of. But in general, they consider that as positive. That's how they measured it and how they looked at it again. They found that the prevalence was about 30% undergoing hallux valgus correction. So relatively common in patients that have hallux valgus deformity, going back to our basics that we kind of went over earlier. They found high intra-observer and intra-observer reliability, which is consistent with literature is saying. And then they found a high number of patients had lesser toe deformity. So about half of them, so around 300 patients had lesser toe deformity. So it's just probably very common for most of our patient population and what we see where we're doing hammer toe repairs. We're trying to do Y osteotomies to help them, or some tendon balancing procedures to try to also help it. Or nowadays, some people are doing minimally invasive procedures to try to correct that lesser toe deformity. And they concluded that the prevalence was about 30%, lesser toe deformity was about 50%. What they were really highlighting, in my opinion, of this paper was that metatarsus adductus may cause different outcomes for hallux valgus. So when you do hallux valgus correction, you have to recognize that metatarsus adductus because it could change your outcomes. Now, this next study kind of showed different opinions on that. So 2015 Foot and Ankle International Level 2 study, so a little bit higher. It's a prospective comparative study. So they had about 200 patients going under a scarf osteotomy for hallux valgus. Maybe we use scarves, maybe we don't. I'm not a huge scarf guy. But in general, that's what a lot of people still use. They used modified Scarletto method. They had two different groups. They had a control group and a positive group. So one that was negative, one was positive. And then they followed them for 2 years. Prevalence, they found about 33%, so maybe a little bit higher than Ayer, but maybe not much difference. Comparable outcomes. So whether you had metatarsus adductus or whether you didn't, and you didn't correct it or not, they still had good results. And so again, they're measuring it, and what they concluded, metatarsus adductus did not predispose the patient to poor functional outcomes. I've had a colleague message me on Instagram saying he's done plenty of bunions with metatarsus adductus and has had great outcomes. And I think that goes back to the bunion talk that I just talked about, is if your sesamoids are in a good position, you get good IM correction, you get good hallux valgus angle correction on the table. Whether you have metatarsus adductus, it might not matter if you hit all those points. But if you have metatarsus adductus and you don't have a good sesamoid position, you don't have a good hallux valgus angle correction, you don't have a good IM angle correction, you might not get the best results with metatarsus adductus. So take that with a grain of salt. I think everybody's needs to look at their x-rays before surgery, so preoperatively. They need to think about it intraoperatively, and then you need to follow your patients postoperatively because we don't have set parameters quite yet to say when and when we should not. Relevance, again, Ayer followed up with his study with more information about the same basically patient subset, but this was in 2015, 2016 timeframe, level 3 retrospective comparison study. They used that same subgroup of patients. They just broke it down to distal metatarsal osteotomies, lapidus, and proximal osteotomies. Again, they measured metatarsus adductus. They had 2 different groups, a control group and a non-control group. They followed for 1 year. So using the same subset of groups that they talked about, they just broke the evidence in a little bit better results. The results of this, I think, were interesting to me. They said recurrence for patients with metatarsus adductus undergoing hallux valgus correction was 30%. The rate of deformity recurrence did not differ among the operative procedure. So whether you did a distal metatarsal osteotomy, whether you did a lapidus procedure or a proximal metatarsal osteotomy, did not affect the recurrence rate. They, however, did measure that the severe deformity were found to have a higher recurrence rate in general. However, if you did a robust correction, that recurrence rate went down. So I know it gets a little bit confusing. If you did a well-rounded procedure, so you did tarsal metatarsal joint fusions 1 through 3, and you fused all of those joints to get better metatarsus correction around that 30-degree mark, they say that your recurrence rate goes down. Now, I think that makes sense to most of us, right? Is this, if you do a well-balanced procedure, you have a severe deformity, you're likely going to correct it through a 1 through 3 tarsal metatarsal joint fusion nowadays, or you're going to add adjunctive procedures to try to help your metatarsus adductus to decrease the chance of recurrence. And I'll show that in a little bit. But I think that was the key point of this study, is that in general, is that recurrence can happen. It didn't really differ whether you did any of those different procedures. However, if you added 1 through 3 fusions with a severe deformity, recurrence rate went down. And I think this is where everybody thought of, oh my gosh, we need to develop a product that helps us get better correction with these severe deformities, and where industry has also kind of added to this, pushing certain products, which again, I think is great because we're trying to help our patients better, but also maybe not everybody needs this based on this literature. The recurrence rate for patients without metatarsus adductus and hallux valgus was still 15%. So still relatively high. I mean, you're still getting recurrence, whether you're doing correction of metatarsus adductus or you're not doing metatarsus adductus correction because they didn't have it, is 15% of patients still had recurrence of bunions. And I think that goes back to what I just talked about, that hallux valgus angle, that sesamoid position, that IM angle. If you're getting those all dialed in based on the previous talk that I did, is that you're going to have likely less recurrence. But we all practice a little bit differently. Some people do lateral alesis. Some people don't do lateral alesis. Some people do lapidus a little bit differently. Some people take big wedge cuts from lapidus. Some people do minimally invasive surgery. So it's very hard to dial in bunions with these type of corrections because we're all doing things just a teeny bit differently nowadays. This is just some pictures of how they corrected it, what they looked like, and some of their outcomes of their bunions and everything like that, which again, I'm not here to critique these x-rays. Everybody has issues with metatarsus adductus and how to fix it better. That's why we're where we're at. But some of these don't look great based on what they're showing us. Recurrence for patients with metatarsus adductus undergoing hallux valgus correction was about 30%. Without metatarsus adductus, it's a 15%, so it's about double the rate. However, if you did a severe deformity with a large correction, it goes down to about that 18%. So it goes back to what would be normal for anybody that's undergoing bunion surgery. So, hey, whether you have metatarsus adductus or you don't, you still have a chance for recurrence, and this is why this is so relevant, is because we don't want recurrence of bunions. Why I did the talk before is that I usually use 3 different type of procedures: a minimally invasive procedure, a lapidus procedure, or a first MPJ fusion, and I try to hit all those radiographic signs that I've been talking about. But in detail, really just pay attention to metatarsus adductus. Know if it's a severe deformity, you likely have to do more of a robust correction, and I'm going to get in the literature about what type of procedures you can try to do to help your robust correction. In general, recurrence happens. It can be double in patients with metatarsus adductus. If you do a more robust correction, it might go back down to what that normal non-metatarsus adductus patient is. And I think this paper really led to the designs that we're seeing nowadays to try to correct metatarsus adductus because of, hey, gosh, 30% is 3 out of 10. That's a lot of people coming back with bunions again with metatarsus adductus, and we didn't like that. My stance is metatarsus adductus is important to recognize. You have to educate patients on it. So if you see it, you got to talk about it. You got to talk about, hey, if we don't correct it and you have the surgery, it may come back. And they just have to be willing to accept that. In my clinic, if they don't want it to come back, I usually opt for first image fusion because that's more of a predictable procedure in my hands, but that's me cheating. But I at least educate my patients on the deformity, their age, what's going on. A younger patient, I'm likely going to be more apt to be more aggressive on it. An older patient, I'm probably going to say, hey, let's cheat a little bit if you're okay with that, depending on what the bunion is like. But everybody's a little bit different. But recognize it and then educate patients on it. I don't think we have a definitive answer for treatment. We have some clear guidelines now, but no clear answer. So that paper that we just talked about said 30% with metatarsus adductus can have recurrence no matter what type of procedure you use. They said it goes back to about 18% if you do if you have a severe deformity and you do a big correction on it, it's likely going to go down to that normal 15% recurrence rate. But is that a guideline, or is that a definitive answer when we have to correct it? No, it just kind of gives you that, hey, you got to recognize that there's a deformity and have to talk to your patients about it because recurrence is a real deal issue. In my opinion, around 30 degrees is when you need to start addressing, and then I think it's a dealer's choice in my opinion. I'll kind of go through that. The plumb line is a nice way to evaluate deformity, whether you should fix it, and then if you get good correction afterwards, and I like it. I again prefer angles, and measuring it due to being very simple in my hands in clinic and quick and easy. But I do add that 3 to 4 degrees to it to get a little bit more accurate measurement. And it's not perfect, but it's simple, less points to click on in an x-ray during your preoperative evaluation, talking to patients about it. That's kind of my just general stance of what we went over. Now let's get into the big evidence. So options available for treatment. Do hallux valgus surgery. You'll leave and watch, but yeah, education is key. I've kind of just highlighted that. Just know that it's a part of our surgeries. Bunions usually come with hallux or with metatarsus adductus. It's what three times more I talked about. And in patients undergoing bunion surgery, it's that 30% to that 35% range, depending on the studies. I personally like to cheat and do arthrodesis in my neck of the woods, so I do a lot of first MBJ fusions all the time for bunions. I'm not scared of doing it. My patients are well educated on this, but I do a lot of first MBJ fusions. Dr. Paul Dayton really taught me at DMU, and he really taught me that you get good bunion correction for that if the joint is track bound. And then my same mentor here up in Fargo, Dr. Uglum, really taught me the same type of principles. Is you want to get a good procedure, want to last the test of time. At first MBJ fusion, it really works well, whether you have metatarsus adductus or don't. And I use my physical exam to guide that. I use that weight-bearing CT scan to really help guide my treatment. So if there's a little bit of arthritis in the joint, I just tell people that, and it's like, hey, just be prepared that it may recur if we don't address it. And if you have some arthritis and a bad bunion, that you might not be as happy as you want. And I could cheat and just give you a good bunion procedure, but your big toe joint might be fused. Other options available for procedures, distal metatarsal osteotomy. The move is usually now minimally invasive procedures, but there are while osteotomies. I'm not going to go into a bunch of while papers on this, but distal metatarsal osteotomies are an option. Proximal metatarsal osteotomies are an option. There are now Lapierre's. I think I'm saying that correctly. I think that's a hard word for me to say. And then the minimally invasive options, which I, again, am always about minimally invasive surgery, but it doesn't mean it's correct. It just means that this is how I like to perform surgery now, is through minimally invasive means if possible. And then I think we all have now been educated on that 1 through 3 tarsal metatarsal joint fusions for these large deformities, the adductoplasty, the other companies that are bringing custom cut guides in or have guides for you to help get better correction and better reproducible, because it's a hard deformity. It's a hard, hey, we know cutting bone, if you take too much bone, you can't get that bone back. So there are certain ways to make it easier for us to do that. And I think companies are trying to help us along the way. Industry is also using the studies, I think, available that we've just talked about to say, hey, why aren't you correcting these big deformities with a bigger procedure? Now, that might not fit every patient, but again, it's available options for us, and there's some evidence for that. And then lastly, there's some other outside thinking. I think you have to kind of talk about everything, and you can't just be narrow-minded. But there's some other options that I'll talk about that there's some literature on. This paper, 2015, Foot and Ankle International, kind of talk about an algorithm for severe hallux valgus with associated metatarsus adductus. It's a technique case series. So they're talking about if you have a skew foot, do a calc slide, plus or minus a gastroc. They talk about doing a lateral release. I think that's reasonable to consider a lateral release depending on what the sesamoids are doing. Then they talk about doing a distal bunionectomy or your lapidus type procedure. Again, going back to that. And then they talk about doing second and third metatarsal-based osteotomy, so the Lapierre's osteotomy, or you can do the fusion procedures based on that. And then you go back and fuse the first TMT, and then you can dial in your bunionectomy type procedure. And then you go back and fixate the metatarsal-based osteotomies. And then you can, if need to, with that lesser toe deformity, do while osteotomies to help correct the lesser toe deformities. Very robust correction, in my opinion. And then you can add an Aiken if you need at the end. And so this is kind of a diagram of what they would show of what they're trying to do. But it's a lot of work to correct this, and this is why a lot of people shy away from correcting metatarsus adductus, because this is a huge procedure. It can cause complications, skin healing if you're filleting the foot open, first TMT, first metatarsal phalangeal joint, lesser metatarsal phalangeal joints, lesser tarsal metatarsal joints, and then you're doing a calc slide. That's why minimally invasive options have become really prevalent, in my opinion, to try to minimize the morbidity. But this was kind of just a good algorithm. Doesn't mean that you have to follow it exactly, but they just talked about being robust in your correction. And that's kind of the operative image that they showed us. So what is the evidence for distal metatarsal osteotomies? The Foot 2020, they had level 3 study, comparison study. They had about 143 patients undergoing hallux valgus surgery. They usually did 1 out of 3 different type of bunion procedures, and then they added some adjunct procedures with that. So they did a distal metatarsal osteotomy, they did a proximal metatarsal osteotomy, or they did a lapidus type procedure. And then they did some additional procedures, which I can't think it makes the paper a little bit flawed because it's not 100% clear why and when they did everything. But in general, they tried to correct the bunion as best they could, whether they added adjunctive procedures or not. They also did pes adductus or metatarsus adductus. Deformity went through lateral distal metatarsal osteotomies, and then they followed them for 1 to 2 years. They found significant improvement of clinical symptoms independent of the method chosen. So whether you did a lapidus procedure, whether you did a minimally invasive bunion procedure, they found that they had better clinical symptoms when you did this. They found that basically the minimally invasive patients, so minimally invasive bunion procedures were the most satisfied. They had non-unions were not observed. So if you did minimally invasive distal metatarsal osteotomies, one of the fear for a lot of patients people and patients when you're not fixating something is, do you get non-unions? In this study, they did not have that. So again, showing evidence that you can break the bone, shift it over, get your bunion correction because you've shifted the metatarsals already, and get good correction, and that these bones are going to heal. I personally found that in my practice. I do a lot of minimally invasive distal metatarsal osteotomies, and I get great results from it, and I'm very happy with it. I'm trying to create the evidence to do a study on it, but it's very difficult because there's lots of different reasonings why I'm doing metatarsus or metatarsal osteotomies, whether it be metatarsalgia, whether it be, hey, they've got elongated metatarsals and I'm doing a bunion procedure and they're having some forefoot pain, or they have lesser toe deformities like we're talking about with these Metatarsus adductus patients. But in general, they didn't get any non-unions of their distal metatarsal osteotomies, which is a good finding. And this is kind of an example showing preoperatively. Here's their lateralizing metatarsal osteotomies. This is them fixating it. And they did a Lapidus procedure on this top one. On the bottom one, they did a minimally invasive mica. So they did a chevron type osteotomy and lateralizing and fixated it that way. Good study, in my opinion. They had high patient satisfaction no matter what type of bunion correction they did, and they did the metatarsus adductus correction with lateralizing distal metatarsal osteotomy. So there is good evidence that you can still get good satisfaction and not have to create a bunch of morbidity by doing a first to third tarsometatarsal joint fusion, which, again, in my hands, sometimes they get non-unions of that, and that can be a disaster if you've taken a bunch of bone with a metatarsus adductus correction. They had low incidence of postoperative complications. So again, a pretty good study overall showing that there's different ways to fixate this, and you can't just say, hey, I do this, and that's the only way to fixate it, and then, in my opinion, get frustrated with patients that show, or providers that show different ways of fixating it just because you don't do it that way. This one is not very high level evidence, but again, it causes distal metatarsal osteotomies. It's JFAST. It's a fast track article in 2021. It's a level 4 evidence, so in my opinion, not the highest level. They only had 2 patients that underwent hallux valgus surgery and metatarsus adductus surgery. They did percutaneous distal metatarsal osteotomies for severe metatarsus adductus. They added percutaneous. Other additional procedures is done as well, so lateral leases and stuff like that if needed. They followed them up for at least 9 months. And what did they do? And this is kind of an example of the correction that they did. And they said all measurements improved postoperatively. They did radiographic measurements, and then they did some functional scores. They did find some delayed unions in the lesser metatarsals, but overall, by the time the final follow-up came around, all achieved full unions. So again, sometimes you have to educate the patient. They might be a little bit more swollen. They might be, hey, you might have a little bit of pain. You might feel some moving, but over time, these will heal if you just give it more time. And I think we all get that when we see a metatarsal neck break, but we don't fix it. It might take a little bit longer. They may be a little bit more swollen than they want over time, but they do usually heal well. And that's kind of what they looked like. It's not the prettiest x-ray, but if the patient's happy, we can't really say that the x-ray tells us the whole story. And that's why I get frustrated when you post something if someone says, I don't like that x-ray. Well, if the patient's happy, you're not there to talk to the patient. If the x-ray looks like crap, but the patient's happy, I think that's what matters. And that is what evidence can show us. That's why doing research can show us these things. And I think that's what I'll highlight throughout this whole study, is that we need more research. We need more people to do research and present their results so we can really compare these, and then ultimately create maybe a multi-center study and doing it different ways, but having the same standards of how to fix it. They concluded that percutaneous distal metatarsal osteotomies were effective in correcting severe hallux valgus with metatarsus adductus radiographically and clinically. So 2 papers showing that doing metatarsal osteotomies distally can work. Now, the second one, obviously not very many patients in it, but the first one, a lot more patients. Now, flipping to the evidence of proximal metatarsal osteotomies, I really like this paper. I learned a lot from this paper because a little older, and I learned a little bit of a new technique because I really never heard of this. But this one was severe metatarsus adductus in children, and it's percutaneous, so MIS surgery. So Journal of Pediatric Orthopedics in 2014. It's a level 2 study, so high quality evidence. Method, they had 34 feet, 26 patients. They did I'm not going to pronounce this name correctly, but they did this type of procedure. So they did an opening, first tarsal-metatarsal joint capsulotomy, and then they did metatarsal osteotomies to align the metatarsus adductus correction. They followed them up for a very long time, so good follow-up. And this is an example of what they did. You can see that percutaneous osteotomy, or not osteotomy, excuse me, capsule release, and then you can see them using a bird to correct the metatarsus adductus at the metatarsal base area, which again is that minimally invasive surgery that we were talking about long time ago. So 2014, this is back before I was even really thinking about metatarsus adductus in my practice, or even as a student and then former resident. But they were doing this a long time ago on children, and they had good scores. So functional scores improved. Radiographic parameters were all normalized at follow-up. So this procedure worked. So they had good outcomes clinically, and then they had good outcomes radiographically, and that's what we can look for. Whether you like minimally invasive surgery or not, they had good outcomes. They fixated it with a pin, so the procedure and everything would stay where they wanted it to. So they released that capsule. They adducted the foot, or abducted the foot after doing the metatarsal osteotomies, and they pinned it so they would leave it there to get the best correction. They concluded that this technique provided relatively easy to perform and feasible procedure. So reliable clinical results, reliable radiographic results, using minimally invasive surgery on kids. And they found after follow-up for a pretty long time that they had good maintained correction. Now, it would be great to have all these patients come back now and then get whether the deformity has stayed corrected or not. But over that follow-up of 55 months, they had good results. Now, other options for proximal metatarsal osteotomies, there's not a lot of high-quality evidence. It's really just technique papers saying this is how I do it, and we now need to do studies on these things to show us what actually works best, what works best for follow-up, what works best for recurrence, and when do you do the correction of metatarsus adductus. But Siegel created a JFAS article for a technique for his Lapierre osteotomies, level 5 study methods. There's really basically just showing how he does his metatarsus adductus correction. And he did first metatarsal, second metatarsal, third metatarsal, and sometimes fourth and fifth metatarsal osteotomies if needed. And again, this is kind of what he did. And he said that he gets good results. It's a technique paper and concluded that dynamic correction of metatarsus adductus deformity so can easily prevent over or under correction using his technique. Now, again, we need functional results, we need radiographic results, and follow-up. But I'm showing you that one, board studies, this is an option for you all. And then second of all, that there is other options going forward treating this for you long term if you want to have different options instead of doing fusion procedures. Now, here's a study that shows some evidence with metatarsus adductus correction through proximal osteotomies, the Lapierre type osteotomies. Foot and Ankle International 2019, it's a level 4 retrospective case review methods. They only had 17 patients, so not a lot. They did proximal crescentic type osteotomies of the first, so a little bit different type of procedure. And then they did abduction osteotomies of the proximal second and third metatarsal osteotomies. And they had a 10-year follow-up, so good follow-up of this. And then they also did radiographic and clinical outcomes of this. They said that the functional scores improved significantly. The hallux valgus angles, the intermetatarsus angles, the metatarsus adductus angles all significantly decreased postoperatively. They had 4 recurrence of hallux valgus. So I didn't go into a whole bunch of details, but you can see up here in this top what their type of osteotomies they did. And again, this is proximal metatarsal osteotomies. These are their radiographs of it. I don't know if anybody's really doing hallux valgus correction anymore with this crescentic type osteotomies, but they had pretty good results with this. They concluded that clinical and radiographic outcomes were pretty satisfactory, so they can achieve correction of hallux valgus and metatarsus adductus deformity, and get significant improvement in pain and function with radiographic good outcomes. Now, this is a study that I recently read and I really liked because I like doing minimally invasive surgery. It's more of a technique paper, but really highlighted that Journal of Orthopedics for the pediatric paper. You have good evidence. They had good functional outcomes. They had good radiographic outcomes. So you can extrapolate that with this paper here, which is maybe just a little bit different because they added a lapidus for more adult deformities instead of pediatric. So 2025 Foot and Ankle Orthopedics. It's again level maybe 5 study technique type guide. Basically, they used a technique to address hallux valgus, which is that lapidus procedure, and then they used metatarsal osteotomies, minimally invasive proximally for metatarsus adductus correction. This is an example where they measured how to and where to cut the metatarsals. I used this paper recently to do my metatarsus adductus correction through minimally invasive means, which led me to want to do this presentation because online sometimes there is hate when you don't know that there is going to be hate based on there is some evidence to do these type of things, and you're an early adopter for that evidence. And these are their x-rays. They did some additional corrections. So they did a skew foot type correction. A lot of these, they did Evans osteotomy, and then they did the metatarsus adductus correction and a lapidus procedure. But that's what they did. They found anecdotal, but they found excellent consolidation and stability. So they found that they get good correction of metatarsus adductus. They all healed well. And they found that they had good stability and their foot did not collapse or didn't get a rocker bottom, and they didn't get a bunch of non-unions from this type of procedure. They concluded that it's a result of a novel approach, but they observed excellent osseous consolidation and stability. They found that minimal risk to patients with the ability to keep the lesser tarsometatarsal joints from being violated. So maybe you won't get a non-union of those joints. Maybe you don't have to take a bunch of bone from that area and then hopefully pray that heals. Now, not everybody likes that because they don't want to just pray that metatarsal osteotomies are going to heal without fixation. But these guys described it in 2 different ways where sometimes they put a pin across it and held the pin just like the pediatric paper, and sometimes they just let them float. And they found that both ways worked fairly well. Now, what is the evidence for the newer studies or maybe the newer techniques that are coming out? These guys, they created that plumb line paper, and they also have done a lot of work with adductoplasty and the tarsometatarsal joint fusions 1 through 3. So JFAS 2025 paper, level 4 case series. Basically, they had 43 patients that underwent hallux valgus surgery and metatarsus adductus surgery. They used novel instrumentation to help correct the second and third tarsometatarsal joints with this combined instrumentation for the first tarsometatarsal joint, which we're very well aware of. They did radiographic evaluations pre and post-op, and they followed them up for a pretty good amount of time, for over a year, roughly, or around a year. So use the plumb line. I like this simple way to say, hey, should we fix the metatarsus adductus or not? And it's an easy way to evaluate your correction. And then they use this novel instrumentation at that time. I think we're all now, from an industry standpoint, been exposed to this, which I think is really awesome to have literature backing it up, and which I think we need, and we need more studies. Results, plumb line measured was 93% positive preoperatively. They converted to a negative reading for following the metatarsus correction about 91% of the time. So they got good correction most of the time, which again, this is what we want. We're not going to always be perfect as surgeons, but we want to have easy ways to reproduce things, and they did get good reproducible results. 7 patients had faint lucencies at the second or third tarsometatarsal joints. So going back to the previous paper, maybe this is what we don't want. We don't want to have the non-unions happen. They concluded that even though they had faint lucencies, they didn't have a lot of pain, so they concluded that they healed. So again, that's just a personal opinion. If I see a faint lucency, I see broken screws in that area, maybe they are stable and they have an asymptomatic delayed union or an asymptomatic non-union, which we all have, so I can't criticize that, but that's just part of the study that I worry about when I take a bunch of bone using wedge cuts is, will that bone heal if I don't get good apposition, or if I do take a bunch of bone and it doesn't heal, will I have a gap later on that I have to try to go back and fix? And those are my thoughts on it. I think, again, a good paper showing that this plumb line does work for preoperative and postoperative measurements, and then a good paper saying that this novel instrumentation, which we're all well aware of now, does work as well, which I think is what we want. We want studies to produce saying that things work or they don't work, and I think these guys are right on par with everything with their studies that they're producing, saying this is a good technique, these are good procedures, and good instrumentation. So I can't fault them for doing this, and I think it is a great paper. They concluded that radiographic outcomes using the instrumentation, triplanar and multiplanar locking plates were used. They had said promising correction of metatarsus adductus and bunions, and they had favorable healing. Again, I think this is what we're trying to do. We're trying to find out what procedure works best for metatarsus adductor correction. Is it using minimally invasive techniques distally? Is it proximal metatarsal osteotomies, whether you open or do minimally invasive, or do you have to do this robust correction of it using fusion type procedures? So good study. We need more research. We need comparison research. We need multi-center studies using the same techniques, same type of postoperative weight-bearing stances, same type of ability to reproduce good literature. Other options, in the metatarsus adductus effect by fixating the syndesmosis for hallux valgus correction. So basically, they take a device and they fixated the first and second metatarsal together using a syndesmosic type device. And they had good outcomes with that. And it's hard to see in this, but no, there are papers and studies showing maybe you don't have to do a bunch of osteotomies. Maybe you can just use a tightrope type device and clamp down the first and second IM angle, and you're going to get good results for hallux valgus correction, and you don't have to do a bunch of hallux valgus work, or you don't have to do a bunch of metatarsus adductus work. And then another study, how to treat metatarsus adductus. So you can do a first metatarsal cuneiform arthrodesis, so a lapidus type procedure, and then doing a closing wedge osteotomy of the cuboid, and that's kind of an example of that. You can see a bunion done or bunion correction done, and then they close down laterally the cuboid to get good correction there. Just options available. Those are the other options. I'm not saying that I'm going to be particularly doing these options. I'm not saying that you need to do those options, but just know that there is evidence or different techniques out there that we at least have to be well aware of in our literature. And so to conclude this talk, metatarsus adductus, in my opinion, needs to be recognized. Education of patients with hallux valgus should be discussed. So if they have hallux valgus and you recognize they have metatarsus adductus, you better bring it up, especially based on those studies for relevance, the relevant findings and the prevalence of that, and the recurrence issues that may occur if you don't address it. And I think it's really important. Just patient education is always on the top of my mind. Imaging, Scarlett method appears to be most consistent and reliable. Plumb line is a new novel radiographic measurement that should be considered. I think it's easy. I think it's reproducible. I think more evidence needs to be done on that, but I like it. And going forward, metatarsus adductus may affect outcomes and recurrence of hallux valgus. So why recognition and education is key, going back to that first point. Evidence on different treatment options. There's no clear winner on what works best because we don't have studies to back all of those up, comparing those options. I think there's 3 different approaches discussed that we just really talked about that have evidence for them: distal metatarsal osteotomies, proximal metatarsal osteotomies, or that more robust fusion type procedure. And I think all have evidence to show that you can do either. You just have to talk about this educational portion with your patients, talk about what they want, and go from there. And then obviously I'm going to add in that you can just cheat and do a big toe joint fusion, and you probably don't need to worry about the metatarsus adductus as much. My stance, we need
future research and standardization on when and how to fix, I think, severe deformity. So around that metatarsus angle of about 30 or metatarsus adductus angle of about 30, we have to start at least considering addressing it, whether you want to do minimally invasive approaches, whether you want to do more robust fusion procedures. I think that's a dealer's choice, in my opinion, but we need future studies to compare that long term and works best and gives us the best patient reported outcomes.
All right, guys, that was the end. If you have any questions, you can always contact me at mcclisterdpm@gmail.com or continue to follow me for continued updated presentations when I post them at mcclisterdpm and on Instagram. Hopefully, we'll be also posting some cases and going through some other educational things. All right, have a great day, guys. Bye.